everyone who's here. I'm not sure if any of you guys were here 2 weeks ago when I did that session. For those of you who are returners, welcome back. For those new people, welcome for the first time. My name's Jackie. I'm a fourth year med student. Technically, I just matched internal medicine. So I'll be starting work up in New York in 2 months. And I'm really excited about today's topic. I'm planning to do cardiology, so this is my favorite subject to talk about. I'm super excited to be sharing this with you today. For those of you who are taking the MCAT or something like that, heart is kind of talked about in the context of physics quite a bit. So I think this will be nice for you guys to just kind of get a base about the way the heart works as a pump. And let's get started. So as a brief outline, we're going to start with the case. Let me know if you don't have that SOAP note / quiz pulled up. I can resend the link in the chat. So we're going to go through a case together, the physical exam. We're going to develop a differential diagnosis and an assessment and plan, and then we're going to talk a little bit about the heart today. So I'm encouraging active participation. I won't be calling on anybody by name. But I will be posing a lot of questions to you guys as a group. So feel free to either unmute yourself and answer. You can send answers into the chat, or you can also message me directly if you don't want to share your answers with the group. But of course, I encourage you to share your answers with the group because we're all here to learn. So I definitely encourage you to participate. Everybody learns better that way. This is what the SOAP note looks like. I like to do a quick overview for those of you who don't know what a SOAP note is, because I didn't when I came into medical school. So we start with the subjective, which is the history of present illness, or the HPI, and the review of systems. So quickly, can someone define for me what subjective means and how that's different from objective? Feel free to type it in the chat. I know it seems like a silly question, but you will be writing SOAP notes every day of your work if you go into medicine. So this is definitely pertinent information. I'm not trying to insult you by going through it. Angelina says it's the information that the patient reports. You're absolutely correct. So subjective means anything the patient directly tells you. So if they say, "Oh my God, my chest hurts," that would go in subjective. That's their history of present illness. And then they might also say, "I have a headache and I've got a bruise on my leg." Those would all be subjective findings. And this is as opposed to objective, which is things that I'm observing as a physician. So this would be the vital signs that I take. Maybe they say their abdomen hurts, but then I press on their abdomen and they're not wincing. They don't look like they're in pain at all. So while in the subjective, it would say abdominal pain, in objective, I'm going to write no abdominal tenderness. So those two things may disagree because, as Angelina said, one comes from the patient and one is what we observe as clinicians. Additionally, any lab tests or images are going to go in objective as well. And then the assessment and plan you develop yourselves, or we're going to develop one together. So this is our kind of global assessment of the patient, what we think they look like, what we think they have, and then we go through all of the problems that they're presenting with. To try to develop a plan of action for them. So I encourage you to fill this out as we go. We like to start by doing this. So you can click Annotate on the top bar of your screen and stamp, and I'll put a little heart stamp down by where I am right now. I'm here in South Florida. I see somebody over here. And I'm about to embarrass myself. I think that's South Carolina, but I am also kind of an idiot. Mouse, I see somebody over here. I don't know why I said mouse when I clicked mouse. I'm sorry. I'm having a brain aneurysm. We have some people up in the Northeast. Hello, I'll be joining you soon up there. We have somebody out here in California. We have some people on the West Coast. Awesome. We have Michigan over here. Fantastic. So we have a big spread of people. Super cool. I'm going to clear this. It's just nice to see kind of where everybody is. I think that's kind of fun. Thank you all for spending your evening with me. Let's keep going. Okay, so this is our patient. Oh, Kenan, I'm sorry, I missed you. Are you down in Texas?
Yes, I am. I knew who you were, Jack.
Oh.
How are you?
I'm well, thank you. Thank you for being here.
Of course.
So we have Mr. Walsh as our patient. So you can start taking notes in your soap note. He's a 65-year-old male who presents to the ED or the emergency department with chest discomfort. And I put that in quotes because a lot of times when you do documentation or when you're writing your note, you'll put in quotes kind of what the patient says verbatim. So if the patient says, I have a tearing pain in my chest, I might put tearing in quotes because that's important that that's how they're describing it and not how I'm kind of synthesizing what they're saying. Whoops. Hello. Okay, case details continued. So what questions, this is a question for you guys, what would you like to ask Mr. Walsh specifically about his chest discomfort? Say you're going to see him in the emergency room. What would you like to ask him about his chest discomfort? No suggestion is bad. How long has it been going on? Wonderful. Yes, we want to know the timing. Timing is super important. If it happened an hour ago, if it happened months ago and it's been kind of getting slowly worse, super important to know the timing. And you'll understand that for some certain pathologies, actually, you can only really treat them within a certain window. So that becomes extremely important when working with the heart. Great one. Any others? How frequent? Yes, that's another good question. We may want to know, is it happening? Is it constant pain? Is the pain coming and going? We may call the pain exertional, meaning does it only happen when you're running or walking or going upstairs? So frequency is super important. That's another great question. Rating of the, Angelina, I'm wondering if you've done something in medicine before, because we always like to do a rating on a scale of 1 to 10 for something like this for pain. So that's a great question to ask. That's important for your documentation. Consistent level of severity, Alec, another great question. We want to know, is it waxing and waning? Meaning, is it getting better and worse? What is that related to? Is it always exactly the same? Great question. Radiation, that's a great one, Isabel. I know exactly what you're thinking about. So we want to know, does it radiate up the neck, down the arm? That points to things specifically. So we'll get to that in a little bit. That's a great one. We love to ask about where's the pain radiating to. You guys are doing really wonderful with this. Any more? These are some of the ones that I would have thought of. And you guys honestly did a lot of these. When did it start? How long has it been going on? Where is it? I know it said chest, but it can be the left side of the chest, the middle of the chest. We call that substernal, right side of the chest. Characterizing the pain. He said discomfort, but some people may say it's like an elephant is sitting on my chest. So we'd want to characterize it like that as well. Scale of 1 to 10. Wonderful. You guys did that one. And we want to know, does anything make it better or worse? Activity, or maybe I took an Advil and it went away, or every time I press on my chest, it hurts. So we want to know these things as well. And a way to remember this is a mnemonic. We use old carts. If you were here 2 weeks ago, I love Osmosis. This is non-sponsored, but Osmosis, please sponsor me. This is a great website for learning how to take histories about patients. And also I used it a lot during medical school for the pathologies. They have these cute little animations and they're always really pretty. So we like to ask old carts: onset, location, duration, characteristic, alleviating and aggravating factors, meaning what makes it better, what makes it worse. Is it radiating anywhere? What's the timing of it? And what is the severity? So you guys did all of those. So this is a little more information, which can go into your SOAP note. So he's saying it's been coming and going for a few months. It is substernal, meaning it's right there in the middle of the chest. It is intermittent and not exacerbated by exercise, which is really important. We'll get to that in a bit. But it's been getting slowly worse over the past few months. He characterizes it when you ask him about it. He calls it fluttering. And I put that in quotes again, because that would be his word, not mine. He says when he drinks caffeine, it makes it a little bit worse. And he says sometimes exercise okay, I'm contradicting myself, but maybe this actually happens a lot, where you'll ask them something and then they'll give you an answer and they'll be like, no, I don't drink. And you'll be like, okay, but how many beers do you have a week? And they'll be like 3. And you're like, what? So this is because I'm stupid, but in life, sometimes your patients will give you conflicting answers and you just kind of got to write both. He says nothing makes it better though. He hasn't taken any Advil or anything. Doesn't radiate anywhere. It's intermittent, as he said before. And he says the episodes last 10 seconds to a minute, which is quite long. But when you ask him about the severity, he says 0 out of 10. He says it's not really painful. It's just kind of discomfort. It flutters. It's not pain. And some associated symptoms. This is not an old cards, but he says that he's also a little nauseous and sometimes also a little lightheaded. I'm going to move on because we have a lot of stuff to cover, but if you guys need me to come back to this slide at the end to fill out your SOAP note, I am happy to do that. Okay, so we've asked a lot about the chest discomfort, but now we have to continue fleshing out that HPI. What other questions would you like to ask Mr. Walsh, just in general as a patient? Family history, great one. Yep, especially anybody coming in with heart stuff, much of it is genetic. So if you have your dad and your uncle both had heart attacks at the age of 50, that would be super important to know. Also, there are some congenital heart defects, things that affect you in childhood. There are some arrhythmias in the heart or abnormal rhythms that are genetically inherited as well. So that's a great question. Medical surgical history, absolutely, Isabel. We might want to know any comorbid conditions like diabetes, or is he obese, or does he have kidney disease? A lot of these things are interrelated, and surgical history is also super important, especially if he's had any heart procedures, any stents, any catheterizations, but really any surgeries is good to know as well. Anything else? You guys are doing great. No answer is a bad answer. All right, so here are some other ones that I had come up with. We want to know, has it happened before? He says it's been going on for a few months, but did he have this in childhood? Has he had this 20 years ago? Like you guys said, family history of heart conditions, super important. Does he take any medications, which can also kind of tell you what conditions he may have. Sometimes patients don't, like, they'll say, I don't have high blood pressure, but then they're on 3 antihypertensives and you're like, oh, so you definitely have high blood pressure. So sometimes you gotta kind of use your clinical reasoning to put some things together. So medications are super important. Any chronic conditions, like you mentioned, medical history, we'd like to know that as well. Surgical history, like you said, especially cardiac. So this is Mr. Walsh's details. He says, I actually had a stroke in 2014 that left me with only partial use of my left hand. I have hyperlipidemia. Anyone know what hyperlipidemia is?
Like high cholesterol?
Yes, exactly. Fancy word for high cholesterol, lipid like fat. So hyperlipidemia and hypertension like high blood pressure. So he has both. He probably didn't use those words. Sometimes people do, but he probably didn't. Hernia repair in 2007, which we don't really care about so much. That was a while ago. And his dad has type 2 diabetes and his mother has hypothyroidism. Social history, he drinks 1 to 2 beers a night and a 20-pack year smoking history. I don't know if I've done pack years with you guys. Does anybody know what that is? I learned that in medical school. This is a fun way that we document this. So pack year is like the equivalent of 1 pack in 1 year. So if I smoke 2 packs a day for 50 years, say, I would have 100 pack year smoking history. So I once met someone who smoked like 3 packs a day for 30 years. And so he had like a 900 pack year smoking history or something. It was ridiculous. Sorry, I did that math wrong. 90 pack year smoking history. So people have these crazy pack years, and that's how we characterize like kind of how much smoke inhalation damage you have. So 20 pack year history could mean he smoked 1 pack a day for 20 years, or maybe half a pack for 40 years. So it's kind of almost like a standardized unit. That's not on the quiz. It's just kind of a fun fact. No illicit drug use. And he takes lisinopril, which is an antihypertensive, and atorvastatin for his cholesterol. Okay, so let's develop a differential diagnosis together. So what would you put on your differential diagnosis for Mr. Walsh? Doesn't need to be super specific. Anything you can think of. We always want to rule out big things, even if it doesn't seem super like it is. Any suggestions? Anyone at all? Am I? Okay, yeah, absolutely. So people can experience, so this is short for myocardial infarction, also known as a heart attack. So this can present in a lot of different ways, especially in women. Guys, women can present with heart attacks that's going to feel like indigestion, and then they're having massive heart attacks. So he's not a woman, but sometimes people can present with heart attacks in different ways. So his chest fluttering, totally, absolutely, we need to rule that out. Great differential. Anything else? All right, this is kind of a tough one if you don't know. Yeah, Alec, you hit the nail on the head. So arrhythmia is a great one. So arrhythmia is like a abnormal rhythm of the heart. So it's not beating kind of at a regular pace like most of ours do. And so classically fluttering in the chest, we call that palpitations. That can be suggestive of an arrhythmia. So that's a wonderful diagnosis. So you guys hit the two giant cardiac ones that I thought of, but again, we can't rule this out. Sometimes I know it's in the chest, but your stomach actually sits quite high in the abdomen. So it could be like GERD or like gastric reflux. He may have a hernia, may have an ulcer. Pulmonary embolism is a giant blood clot in the vessels leading to the heart, or leading from the heart to the lung. And so if you get one of these giant clots, you can actually die pretty quickly. And that presents usually with just kind of shortness of breath. Doesn't really sound like something Mr. Walsh has, but this is one of those never missed diagnoses that can kill you right away. So we gotta look out for that, and we gotta look out for myocardial infarction, like Isabel said. Arrhythmia can kill you, absolutely, but these are kind of the main ones. So we're gonna do the physical exam. He is not febrile, no temperature. How's his blood pressure look, guys? Normal, concerning, low, high?
Pretty high.
Yeah, I think it's a little high too, especially if he's on blood pressure medication. So that might mean he's not taking them. He may just be really stressed, but we like to see 120 over 180. Oh, over 80, sorry. 120 over 80 is like a perfect blood pressure. So it's a touch high. Heart rate, what do we think? Also high. Does anyone know what the normal range of a heart rate should be? 60 to 90 is so close. So 60 to 100 is considered normal. So below 60 is called bradycardic, and above 100 is tachycardic. So technically he would be tachycardic and hypertensive. I'll tell you, this is just a touch high respiratory rate. We want it around 16. And he's saturating at 96% on 2 liters nasal cannula, which is that little tube that snakes under your nose and with the 2 little things. So this is actually a little low, even on supplemental oxygen. So I actually don't know why I put that in there, but he's not oxygenating well. He may be obese. He may have a lung condition. I don't know. So he's sitting up and he's in some mild distress. Who wouldn't be when they're having heart stuff? On chest exam, we press on his chest. He's non-tender to palpation. We listen to his lungs and it's clear. No wheezes, rubs, or rhonchi. So wheezes is like asthma sound. Rub is literally, you can hear the pleura of the lung kind of rubbing against the other pleura. And rhonchi is kind of like a crackly sound. So then we do, so his lungs sound fine. I don't know why I did this with the oxygen, to be perfectly honest with you. Cardiac, he is tachycardic, as we saw here on the vitals, and he has an abnormal rhythm. Now, this is consistent with that fluttering chest sensation that he had. So abnormal rhythm, meaning it's not going lub-dub, lub-dub, lub-dub. Normally it's going lub-dub, lub-dub-dub, lub, lub-dub. I sound like an idiot. I'm trying to tell you that it's not like a normal pace. Normal S1 and S2, we'll talk about what that means. And no murmurs or rubs. So no murmurs, we'll talk about murmurs in a little bit. And no rubs, which is kind of similar to these rubs actually, except this would be the pericardial sac, which is the sac that surrounds the heart rubbing. And that can be indicative of inflammation in the pericardial sac. So no pericarditis. Vascular, his pulses were 2+, which is normal, which means that when I pressed on his finger, or sorry, that's cap refill. When I feel his pulse, like in his wrists and on his ankles, I feel that strong pulse. So he's perfusing well in his extremities, which is a good sign. Press on his abdomen, it's soft, non-distended, and non-tender to palpation. Again, I can always circle back to this at the end. Okay, so we're going to get the all famous EKG of him. Last year, I did an EKG reading session that people liked. So let me know if you want me to do an EKG reading session with you guys. I always think those are kind of fun. Especially if you're going to do some work as like a scribe or a medical assistant, or if you're planning to go to medical school, you can wow your peers with your EKG skills. So I don't expect you to know how to read this, but the main thing I want you to look at, remember how I did that stupid Lub-Dub thing a minute ago? That was kind of signifying how the rhythm that the heart was beating. So we call this peak here the R peak, which is kind of the tall pointy peak here. This is the best lead to do it on, unfortunately. It's going down, but that's just because of the conduction in the heart. So it's not bad that this one's going down, but this is the R peak. And if you look at the distance from this R to this R versus this R to this R, you'll notice that they're not the same. So if you were to like take a little ruler and march out how far each of these is, you would notice that it is not consistent, as it should be for most of us. So this is indicative of an abnormal rhythm. That's one of the first things that we would notice about this EKG, and really the only important thing I want you to see. So this is actually suggestive of his diagnosis, which I will share with you here. So we are moving on to the assessment and plan of the SOAP note. Mr. Walsh. So I learned it like this, where you give kind of a summary statement where you put together everything that you've gotten from him. And then you develop the plan underneath it. So this is how I do it. So he's a 65-year-old man with hypertension, hyperlipidemia, and a history of a stroke, which we'll talk about why that's important and why I'm putting that here later. He presented to the ED with intermittent chest palpitations. His EKG demonstrated atrial fibrillation with no ischemic changes. We know that because, can I go backwards, please? This ST segment, I don't know if you guys have heard of a STEMI or an ST elevation MI. That's a type of heart attack. So that's this segment here. We see a tombstoning pattern when we're seeing ischemic changes in the heart. So we're not seeing anything here, which means he's probably not having a heart attack, which is great news for him. So that's why I was able to say that from the EKG. So as far as what we're going to do for him, atrial fibrillation, but we ruled out, or RO, and MI, which is important for documentation so they know we're not missing something that's going to kill the patient later. So we're going to do an ambulatory EKG, which means we're going to keep him on leads and watch him continuously on a monitor to make sure that his rhythm doesn't start going too quickly or too slow, or that he doesn't develop a heart attack later, because sometimes early heart attacks can actually result in abnormal rhythm. So we want to keep him on that for a little. We're going to do an echocardiogram, which is like an ultrasound of the heart, given his history of stroke. So that's why I kind of honed in on that, to look for clot formation with the bubble test. And I'm going to show you some pictures of that in a little bit, so no worries about that yet. But we are going to do some imaging of the heart that way. We will start him on blood thinners, which I'll also talk about in a little bit. And we're going to have him discharged pretty soon, I think, since he's not having a heart attack, and encourage him to follow up with cardiology, of course. I even made a little note here. I know this is a lot of stuff to take in, but I promise this will all make sense as we learn more about the heart. This is my favorite thing to talk about. I'm super excited. All right. So the heart comes in kind of two parts. There's the plumbing part and there's the electricity part, and we're going to talk about both. So as far as the plumbing goes, that's kind of the flow of the blood through the heart. And you'll notice that there's the left side and the right side. The left side is the oxygenated side, often shown in red, and then the deoxygenated side here is shown in blue. And then here you can see the lovely electrical system. It starts up here at the top and goes down, and we'll talk about each of these in detail. So these are the chambers and the great vessels of the heart. They are actually called the great vessels. It's not just because I think they're cool. So I want someone to either, if you can, to unmute or to type up in the chat. Can you describe the flow of blood through oxygenated blood through the heart? Let's start you here in the pulmonary vein. Can you talk me through getting all the way from here down into the systemic circulation? What structures do I traverse? We can type it out. We can unmute. I'd like someone to give it a try though, if you can. Anybody? How about from the pulmonary vein? Where do I go? Left atrium. Thank you. Thank you, Tisha. So I go from the left atrium, I pass the mitral valve, I go down into the left ventricle here, and then I go up through the aortic valve, which leads us into the aorta. And then from here, I go down into the rest of the body. So this big aorta arcs down and vessels come off. Here, these are going up into the neck and into the brain and into the arms here. And then a bunch of other offshoots come out back here behind the heart that go to your abdominal organs and your legs and such. So can somebody do the deoxygenated blood? So, oh, I should know, these pulmonary veins, what do we think they're connected to? Lungs, yes. Thank you, thank you, thank you. So this is oxygenated blood coming from the lungs. So when you take a deep breath in, that air goes down into your lungs and then it diffuses into these pulmonary veins and brings blood, oxygenated blood, into the left side of the heart, which is then pumped into the rest of the body. I want to make a note here about the heart. Somebody really cruel did this. So you'll learn in medicine that usually artery means oxygenated and vein means deoxygenated. But the only exception to that in the body is here in the heart, where the pulmonary vein actually brings oxygenated blood. And here, the pulmonary artery is bringing deoxygenated blood. And that is the only exception you will see in the body. Everywhere else, artery means oxygenated and vein means deoxygenated. I don't know who did that, but they messed up big. So now, can somebody bring me on a journey? So now all of the deoxygenated blood from the upper half of the body is coming here through the superior vena cava, and all of the deoxygenated blood from the lower body is coming up here through the inferior vena cava. Can someone bring me on a journey like we did for the oxygenated blood back into the lungs? Vena cava, right atrium, right ventricle, pulmonary artery, lungs. Woo! Thank you. Awesome, awesome, awesome. So that is the journey that we take to bring deoxygenated blood back into the lungs. And so remember when I said that pulmonary embolism that can kill you really quickly, that lodges right here. So if we were to get a clot here, we would have no blood going back into the lungs, and then therefore no blood would be able to return back into the heart and be pumped to the body. And that's why you can die so quickly from that. So clots here are quite bad. Clots anywhere are bad, really, but this is a specific type of bad clot. All right, here's the Lub-Dub that I was doing earlier and making a fool of myself for. So when we listen to the heart, we remember on that physical exam, I said normal S1 and S2. So these sounds are represented. The heart is making a sound that we're hearing, and that sound is the closing of these valves here that we see. They're kind of represented by these little teeth looking leaflets here. So when those snap shut, they actually make a sound. And that's why when you listen to someone's heart, you can hear it beating. It's not the heart contracting, it's actually the valves closing. And we hear two sounds, but there are four valves, but two close at once, which is kind of cool. So during S1, this is contraction of the heart. And that is going to, so picture this bottom part of the heart here squeezing upwards, like squeeze the heart from the bottom like a ball. And then think about how that would push blood up through the aorta and also simultaneously up here through the pulmonary artery if this bottom part's squeezed. And then you can think about like kind of physics. If this is squeezing up, that's going to close this one-way valve shut, which is why these valves are closed. And that's the S1 sound. And during S1, blood is flowing up through these two open valves, and we're hearing the sound of these two close. Now, when the heart relaxes during S2, you can think about this ball, then it kind of expanding back down. These one-way valves will close here and here, and these two, which is the sound of S2, and then these two valves will open, allowing blood to fill back into these two ventricles down here. It's a little confusing, but I think if you think about it like a squeezing ball, it kind of makes a little more sense. But where it's kind of fun to think about, we're pumping oxygenated and deoxygenated blood out at the same time. Heart's a very cool thing. So talk a little bit more about that. So this is kind of what I just said, but being illustrated to you again. Ventricular contraction, again, the squeezing of this lower ball pushes blood up and up. And then diastole, or the relaxation of the heart, is blood spilling back and back down. So this is a way that we kind of characterize the pressures in the heart. I don't believe this shows up on the MCAT, but you'll certainly see this in medical school. So this is one of the ways that we can kind of characterize the pressure in the heart. So you can think about it here. When the aortic valve is opening, meaning this one here, that would mean that this bottom part is squeezing up. So that would mean the pressures up here are increasing a lot because this chamber is becoming smaller as the muscle contracts. So that's why you would get this big pressure jump here. And when we have valvular pathologies, or when we have maybe this valve is calcified, so you may hear about like aortic stenosis is a common one, or mitral regurgitation is another common one. So when we have issues with the valves, that causes pressure differentials, which we can see on the charts like this. I also mentioned, I'll note here that we're talking about valve sounds. Something that does show up on your MCAT is they talk about that like Bernoulli equation or whatnot with the flow of the fluids, and they talk about turbulent flow and laminar flow. So what's the difference between turbulent flow and laminar flow? MCAT folks or physics folks? No? That's okay. So laminar flow is like linear flow. So that would be flow through a normal heart. Line going down, line coming up. Turbulent flow is like, imagine water in a stream hitting a rock, and you kind of see that water kind of dance around and form little swirls and stuff. So the valves in the heart can kind of do that too. So when you get vegetations on the heart, like endocarditis, when you get like things growing on the valves, or say the valve, I mentioned this was a one-way valve, but sometimes it doesn't close properly and it stops acting like a one-way valve. And when this valve is supposed to be closed and I'm supposed to be pushing blood up through here, it can actually spill back into the left atrium. And that can cause a lot of issues. So when we hear that turbulent flow, meaning when it's kind of, when the blood is moving around objects that aren't supposed to be there, we can actually hear that sound as a murmur in the heart. It'll sound like a whooshing that wasn't supposed to be there. We're supposed to just hear a clean S1 and an S2, but when we hear whooshing between, that's the sound of blood rushing past something that isn't meant to be there. So that was what the murmur meant. So murmurs usually mean something is wrong with one of the valves. And depending on where that murmur falls, is it between the Lub-Dub? Is it before the Lub-Dub? That can actually tell us which valves it is, because we know that 2 valves close at a time. So that helps us to narrow that down. Thought that was kind of a fun physics connect. For those of you, I didn't like physics until I got into cardiology, and now I hate it a little less, but I still don't really like physics all that much. So since we're talking about blood, let's talk about heart attacks. We talked about MIs and how that's the thing not to miss, super important. So MI is a myocardial infarction. So the reason that these are so bad is, remember when I said when during systole, the bottom of the heart contracts and blood will go up through the aorta to supply the rest of the body? Well, the heart itself is a muscle too. And so some of these little offshoots that come off of the aorta during systole actually go back in and supply the muscle of the heart itself. So these vessels are quite small. And so if you were to get a block here or a block here, imagine what happens to tissue that isn't being perfused.
It dies.
It dies, exactly. So if you were to get a block here, all of this muscle down here would die. And what happens when it dies is it does not receive electrical conduction correctly, or it messes with the electrical conduction that can cause abnormal rhythms. But more importantly, that can cause this part of the heart to not pump properly. So they actually call this vessel the widowmaker. That's not the actual name of the vessel, but they call it that because you can see how this supplies kind of this money part of the heart, this bottom part that contracts to bring blood back out up to the aorta. So if this vessel gets blocked, all of this tissue dies, and pretty quickly too. So that's why this vessel is quite dangerous. But you can really get a block in any of these. So that's why people will go in and stent. I think I have a stenting picture here. Yes. So what do we do when someone's having a heart attack? The question that we were asking him, when did it start? Excuse me, why onset was so important is because we actually have a window in which we can stent these patients. So we'd like the door to balloon time to be under 90 minutes. So when someone comes in with chest pain, it's really important that they tell us when it started. So what we'll do is we'll inject dye into the heart, and then this dye is here coming down into this vessel right here. So we're seeing this kind of spider out, and here you can see a block right there. You see how there's a gap between this and this? So you guys are being cardiologists now. You're seeing a little block between here and here and here and here. So we can open that up with a stent. So we're going to thread the balloon down through this wire, which is coming through a vessel in the arm or the leg. And then we're going to open up a balloon that's going to expand kind of like a metal cage or stent. And that's going to hold the vessel open. That's being closed by calcification or buildup of fat in the vessel. So a lot of times people, when they say they're going in for stenting, that's what this is. So I think that's kind of fun. I'm sure that you've had people in your lives that have, well, I hope not, but a lot of us know people in our lives who've had scares with heart attacks, or maybe say they have a stent or say they had a cath. That's what this is, which is pretty cool. I think it's cool. All right, so now we're going to talk about the electricity of the heart. So let's talk about nodes. There are 2 major nodes in the heart, the sinoatrial node and the atrioventricular node. And we can remember that because this one just has atrial, and we remember that these 2 top portions are called atria, and these bottom parts are called ventricles. So the sinoatrial node is the top one, and the atrioventricular node is between the 2, which is a good way to remember it. So the conduction starts here, we get a little zap, and then it travels down the atria here to reach the SA node, and then it will come down these Purkinje fibers, down the bundle of His here. This is the bundle of His, and then up through these little Purkinje fibers. And as the conduction comes down here, this electricity is what causes the heart to contract. Think about like you were getting tased or shocked, which I hope you never have. I haven't. I'm just guessing it probably is quite bad, but it kind of caused your muscles to like contract. And so that's kind of what's happening here. It's almost like shocking the heart. So it like contracts and pushes that blood up through. And that's what's causing the pump to work properly. So I kind of just did it, but I think this is a quiz question, which is why I have it here in the side. So I'll just tell you that we go sinoatrial, AV, bundle of His, Purkinje fibers. And that's the flow of conduction through the heart. And I can talk you through a normal EKG quick too. So if you guys want the EKG or if you don't, it makes no difference to me, but just put it in the little comment thing at the bottom if that's something you'd be interested in. So this little bump here is the bump that represents these atria contracting. So as the electricity comes down the atria, they will squeeze, and that's this little bump. And then this big one here is the contraction of this bottom part. So that's why we get little bump, bump. And then this bump here is the depolarization the repolarization of the bottom. So that's once this is relaxing, that causes a little signal as well. So it's atria, ventricles, repolarization of the ventricles. Now let's talk about dysrhythmia. So we said arrhythmia, and I want to make a correction here. I'm a stickler about heart stuff. Dys means like bad or incorrect. A means not, like asystole means no, the heart is not beating at all. And this is one of my biggest pet peeves ever is I'm going to ask you all, and I'm going to hope you get this right on the quiz now that we're going through it. Is asystole a shockable rhythm? Can you go clear and shock someone when they're in asystole? No, thank you. No. You're going to see it on every medical drama. And I'm a big Grey's Anatomy person. I don't care that it's not correct. I love it. But it's just you can't do it. You can't shock a dead heart. So we can inject medications that can restart the heart to pump, but you can't shock a heart that's not pumping. You can shock a heart back into a normal rhythm if it's abnormal. So arrhythmia is actually kind of not a great word. Dysrhythmia is a more correct way to say it. No one is going to be like me about this. Probably I'm being obnoxious. Arrhythmia and dysrhythmia mean basically the same thing, but I like dysrhythmia because it's more correct. But if you don't want to start fights in the hospital, just say arrhythmia. So abnormal conduction of the heart is what a dysrhythmia means. So that means that the heart's not, the conduction system here, something's working kind of wonky. Maybe the SA node isn't firing. Maybe something is firing randomly from over here, and this is starting its own conduction, and that's causing the heart to beat off beat. Maybe the conduction starts here and then goes down here and then stops and doesn't get all the way down the heart. That's another condition. So there's lots of ways that this can be messed up. Atrial fibrillation is one of the big ones. So atrial fibrillation, as the name suggests, is a problem up here with the atria. So that's the one I was describing first. That is where instead of the signal starting in the SA node like it normally does, we're going to develop an autonomous part somewhere else in the atria that's going to start its own signal. It just like went rogue and decided to start its own signal and kind of start conduction down the heart. So that's the reason that instead of lub-dub, 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 normal, we're getting this crazy, weird, wonky rhythm because some other site in the atria is like starting its own ventricular contraction on its own. It's starting up here and causing the ventricles to contract totally out of whack. So that's why we get that weird, abnormal rhythm. Did I just skip a slide by accident? No, I went back by accident. Ventricular fibrillation is kind of similar, where we may get abnormal signals starting down here. And that can cause a fatal rhythm as well. Heart block, as the name would suggest, is the other one I was describing, where the electricity starts up here and then gets all the way down to the AV node, and then it stops. It pauses, it waits too long before coming down into the ventricles, and that's called a heart block. So that would actually lead to, one of the types of heart block can lead to a lengthening between these two peaks, because we remember that this was the atria and this was the ventricle. So if this part's extra long, that means that you have a block here in the AV node. So what modality do you think we're going to use to identify dysrhythmias? What test would you order? EKG, absolutely. EKG is easy, quick, simple, cheap. We're probably going to do an echocardiogram or that fancy ultrasound of the heart as well to look if the chambers are expanded. We can actually see in real time if the chambers are contracting appropriately. But that's not going to be our first line. First thing we do for everybody is an EKG. All right, so electrical question. What do we do when someone has an abnormal rhythm? So there's a couple things. Does anybody have any ideas? This is kind of a strange question, but does anyone have any thoughts about what we might do if someone had an abnormal rhythm? Anything you can think of, things that bring people from abnormal rhythms back to normal rhythms. I mentioned a couple of them earlier. That's okay. It's been a long day. Oh, I didn't put the answer. I'll just tell you. So we can't, I think I have a slide about it. I'm gonna pause because I think I have a slide about it somewhere. Blood thinners, yeah. Well, so blood thinners are, we put most people with arrhythmias on blood thinners, absolutely, not to stop the abnormal rhythm, but to prevent stroke. And I'll talk about that in a second, but that's a wonderful, wonderful point. Pacemaker is a great one, Alec. So you can implant pacemakers into the chest wall, which can kind of pace the heart for itself and keep it going. So this is actually one of the reasons I shouldn't laugh. I laugh when I'm uncomfortable. When people sometimes die when they have pacemakers in, that's why sometimes you'll still see their heart beating, because although they have died, the device is pumping their heart for them. So pacemakers are great devices. This is actually the kind of cardiology I want to do, is called electrophysiology, where you put pacemakers in. Super cool, coolest field in medicine, I think, but I am extremely biased. EKGs are great for identifying abnormal rhythms, but can also be helpful for identifying ischemia, like in a STEMI. So that's, like I said before, this ST segment, which is right here at the end of this complex, will be up here in a tombstone pattern if we have an ST elevation MI or a STEMI. And so that's a good way to quickly screen for heart attack. We do other tests as well, but that's a good quick one. So EKGs are super helpful for a ton of things. All right, this is the slide that I thought I had, and I did, it was just later. So here, there's a couple things we can do. We can cardiovert and we can defibrillate. So this is when people say clear, and then they shock them. There are two different ways that we can do that. And I did learn this in medical school. I didn't know this before. I thought they were the same thing. So we can cardiovert, which means you can kind of electively shock someone. So this isn't you running into the room screaming with the paddles and shocking them because they're about to die. We can kind of see that they're maybe in an abnormal, maybe an atrial fibrillation or something, and we want to shock them at a lower voltage to try to get the heart to beat normal. It's kind of just like slapping someone and being like, God, you know, what am I thinking of? Snap out of it. It's kind of like slapping the heart and saying, snap out of it, get back to it. It's kind of what cardioversion is. And then defibrillation is the one where people are like panicking and somebody like passes out, and then you go put those little AED pads on them and it goes, abnormal rhythm detected, clear. And then it shocks them with a really big thing. That's this one. That's the one where they have those AEDs all over public places. That's to do this, not this. This you do in the hospital. So fun fact that there's a like a light version of the defibrillation. Yeah, so that's what this is here. And then this is what Alec was talking about. So they have pacemakers that are also ICDs, which are internal defibrillators, basically. So it's kind of like taking this big device and making it really small. So a lot of these can pace the heart and like keep it going a normal rhythm. But if they detect a fatal rhythm, they can internally shock the heart back into a normal rhythm. And I know some people who have these, and they say that when that thing goes off and it detects an abnormal rhythm and it shocks you, it feels like you're getting kicked in the chest by a horse. So it's like really quite scary. And actually, a lot of these people like kind of live in a state of fear of, oh, I don't know when my device is going to go off, because they can't control when their abnormal rhythm happens. And it like kind of freaks them out, because imagine you could just be kicked like internally in the chest by a horse, like at any moment. So it's something I didn't even think about until I talked to some of these patients, but it kind of gives you a little perspective on that. So it's not a cure-all. It comes with its own risks as well. So that's another fun way you can pace rhythms. So I wanted to bring us back to the case. and talk a little bit more about Mr. Walsh. So I think we understand why some of these things are happening now that we know a little bit more about the heart. So ambulatory EKG, we want to keep a watch on that rhythm, keep a watch that he's not going too fast, going into a fatal rhythm, going into a heart attack, something like that, because we don't know if he has clots in the vessels. You mentioned blood thinners, Isabel, and that's wonderful. That's one of the main things we want to put him on. And I think we can understand now why. So in atrial fibrillation, which affects the left atria, this chamber is kind of like fluttering abnormally. It's like shaking almost, which means it's not emptying out appropriately. If this chamber is shaking, then it's not appropriately going to push all the blood down here into the left ventricle. So what ends up happening, because there's kind of stagnant blood in here almost, is it will clot. Stagnant blood clots. So if this blood clots and gets kind of thick, and then it pumps one of those clots out, that clot is going to come down here into the left ventricle, go up the aorta, and can actually travel all the way up here into the brain. And that's likely why Mr. Walsh had a stroke before, because he's been in atrial fibrillation for quite a long time, longer than he even thought he was. And that's likely what caused the stroke. So we're going to definitely put him on blood thinners, try to break up some of these clots, try to discourage clots from continuing to form so he doesn't have another stroke from that blood going up into the heart, blood going up into the brain and clotting. So that's a big one. Something we can do to test for another thing is we can, if you have clots that form in the lower legs, called a DVT, you may have heard of them. They can actually come up from the legs. Deoxygenated blood can come up from the legs. And then there's actually a way that blood can get through this septum that should be totally solid. But when you're like forming as a baby, there's actually a hole here that gets closed as you grow. But sometimes this hole is open. So sometimes you can get clots from the lower legs that can come up here through the deoxygenated side of the heart and jump across to this side and then still go up and cause a stroke again. So because we want to know why he had the stroke, is it because of this, or is it because clots from anywhere else in the body are jumping across the septum because of a birth defect and then going up into the brain? We may do what's called a bubble test, which means we inject bubbles basically, which doesn't hurt you. Intuitively, I kind of thought it was like gonna hurt the person, but it's actually totally safe. So they like agitate a bunch of saline and like shake up a bottle, and then they inject it here into this side of the heart. Well, into the vessel that goes into the side of the heart. And you can actually see here the blood. This is the agitated bubbles here in the right atria. And we're checking to see if they jump across here, which is kind of fun. So we would see through this bubble test if the bubbles moved, and that would mean you had a birth defect. So it might be fun to check that. Not too bad for the patient. And then we start them on blood thinners like Isabel suggested as well. These are my sources. I know that I've been talking really fast. I'm here to answer any questions you have. Do you have questions, comments, concerns? Do you need me to go back to any slides that we've gone through? Not too much time left in the hour, but I'll hang out if you guys have questions that you want to ask. Yes, I absolutely can. Here. Thank you guys for sticking with me through this very long presentation. Let me know if you want more heart stuff.
Yes, please. This is fun.
Good. I'm glad you guys had a good time with it. Anytime. Thank you, Isabel.
Let me ask you something, Jackie. What in the world is brain aneurysm, and why do you have it, if I ask?
That's a big question. So a brain aneurysm, an aneurysm is like an outpouching of something that isn't supposed to outpouch. So it's kind of like a weakness in the vessel wall in the brain where it kind of Think about like a balloon where you can blow it up and it expands. Imagine a piece
Mm-hmm.
of a larger vessel like has a balloon almost on it. And so as the blood is going through it, it like pouches out and can become quite large. And the danger of an aneurysm is that it bursts. And then you can imagine if there was a lot of blood in the aneurysm, that can cause a stroke, a hemorrhagic stroke. So you can like lose a ton of blood in the brain. And then having all that blood in the brain can cause damage. So that's why a lot of times they'll clip aneurysms. They'll kind of like clip around the base of that balloon I was describing so that it doesn't burst and cause like a huge leak of blood into the brain.